Hi, I'm Dr. Ramon James, cardiothoracic surgeon here at Doctor's Hospital, and welcome to a day in my life. My day started off at about 6 this morning. Um, had a quick breakfast and then made my way out. It's going to be a busy day. Today is my operating theater day, and I'll begin by doing ward rounds, which usually takes about an hour to an hour and a half. And from there, go straight into the OR. So we expect that we'll be able to start our cases today at 9. We actually have two cases booked. They're thoracic surgery cases, so no cardiac today, but excited, and they should be two good cases, nice and short, probably about 2 hours long each, if that. So yes, let's get started. So we'll start our ward rounds this morning. I have two patients to see. The first is a gentleman who had a pleural effusion. That's fluid around the lung with some collapse of the lung on that side. I placed a chest tube, and we're going to review him and see how he's doing. It's very important when you start the ward rounds that you first begin by speaking with the nurses who have been with the patient overnight. They'll be able to tell you all things that have transpired, any major issues or concerns. And a part of the process is to look through his vital signs, his blood pressure, etc., as well as his medication, ensure he's getting his physiotherapy, using his incentive spirometer for deep breathing exercises, and just to see what the drainage from his chest tube has been overnight. So let's go in and see how he's doing. We finished our ward rounds and we're about to start our two surgical cases today. They're thoracic cases. The first is a young guy in his 20s with what we call a spontaneous pneumothorax. So he has some air leaking from the lung, resulting in lung collapse, and it hasn't settled. So we have to do a lung biopsy, remove that bit of the lung, and then we'll do what we call a pleurectomy and pull the line, strip the lining of the chest wall to get the lung to stick to the chest wall, preventing this from occurring again. We're going to do it minimally invasive with small incisions, 1 centimeter incisions, and as we know, that increases his better patient outcome, shorter in hospital time, etc. Our second patient is an older guy, middle age in his 50s, with a bad pneumonia, resulting in, again, lung collapse and some fluid collecting in the chest. He's not settling with antibiotics, so we're going to have to go in and basically wash everything out and leave some drains in. So that's the plan. Two nice cases. We'll get changed and get started. Okay, guys, so we finished our rounds and we're here in the OR, and we're scrubbing, which is a part of the anti-sepsis protocol to decrease the chances of any infection in our patients. So the first scrub is the longest scrub of the day. As you can see, it's a no-touch technique, so you're not able to touch anything. That's the purpose of the foot pedals. And we go from top to bottom, all right from the hand all the way down to the elbows, and we start our scrub. This is it. This is the time just to get focus on what's to be done, and we're all set and ready to go. Okay, guys, so we're all prepped, ready to go, ready to start the first case. As you can see, we have on our PPE, You can't touch the door when going in with the hands, again, to prevent contamination. So I'll just use my back and head in, okay? Good. Okay guys, so we finished the first case. Went well, as planned. Well, we did it minimally invasive via VATS as mentioned. And we were able to do what we planned. The surgeon is not the most important person. That's only about 20 to 30% of the entire process. It's really a team. So the anesthetist will wait the patient. We will get him into the recovery room once he's settled, and we'll repeat a chest x-ray there to make sure that everything looks good. Then he'll head up to the ward. All right, so after that, they'll prepare for the second case. And in the meanwhile, we'll go and have a seat and have some lunch. We're all set and ready to go with our second case. As mentioned before, is a slightly older guy, bad chest infection. We won't be able to do this one minimally invasive, so he'll get an open procedure. We'll make a slightly bigger cut and go in and wash out everything, make sure that the lung is fully re-expanded after, and leave some drains in, and he should be fine. So we'll see you after. We've completed both cases. Everything went well as planned. We're back here in the office. Our first patient is out of the recovery room and back on the ward. His x-rays look good following surgery. Our second patient has been moved out of the OR and into the recovery room. He's awake, a bit drowsy from all the medication, but we're pleased with the outcome. This here shows his chest x-ray before surgery. There's quite a bit of fluid here and some lung collapse. We're able to go in, wash out all of that infected material, and we got the lung to fully re-expand, and we left some drains in, and he remains stable throughout the procedure. So from here, the work really starts. The team today did an excellent job getting the patients into the OR, ensuring that everything was done efficiently as well as safely. And it was a good day, a productive day and a successful day. The work now begins. We'll leave here, we'll go on the ward, do a quick ward round to ensure that all patients from this morning are okay. And yeah, we take it from here. Okay guys, so we're finished today. Both patients doing well. No issues, really happy with the chest x-rays, and they're doing well. So now it's time to get to the non-medical side of my life, where we'll try and get some exercise in, probably about at least 45 minutes, get a bite to eat and catch up with friends and family. And that's it. Thanks for hanging out with me. It was great having you, and hope to see you again soon.